Hi, very good morning. I'm Dr. Janak Patel. We'll be starting with I'm a MD physician. I'm not an endocrinologist, but whatever I've gathered from internet, I'm presenting in front of you. We are going to talk today on hyperandrogenism, meaning increased level of androgens, maybe in a male, maybe in a female. So we are going to discuss regarding hyperandrogenism, also called as adrenogenital syndrome, or you can call, because one of the most common cause is congenital adrenal hyperplasia, which will end with adrenogenital syndrome. So we'll be discussing on the common headings as usual: definition, etiology, pathophysiology, clinical features, investigations, differential diagnosis, treatment, and complications. Meaning is very simple. Hyper means more, androgenism means increased level of androgens. It is a common endocrine disorders of women, because in men it usually produces less number of symptoms, but can also be symptomatic in case of a male also. The prevalence is 5 to 10%. Androgen will stimulate the growth and increase the diameter and pigmentation of hair, and that is the main effect of androgens in female. So source of androgens in female mainly from ovary, and those are testosterone and androstenedione and dihydroepiandrosterone, and that particular is also derived from adrenal gland, but the amount of that from adrenal gland is very small in female. Testosterone is a major circulating androgens in a female, and it is approximately 1% of free testosterone which is circulating in a female. There is one group of disorder called as a congenital adrenal hyperplasia, which is an autosomal recessive. It is an inherited disorder, and there is a deficiency of one enzyme which is 21 dehydroxylase enzyme, which will be converting cholesterol into cortisol, mineralocorticoid, and also helps in conversion of progesterone into estradiol and testosterone. Now, this particular disorders will result into elevated level of ACTH and overproduction of and accumulation of cortisol precursors. But along with that, there is a decreased production of what we call as glucocorticoids, mineralocorticoids, and there is an elevated level of androgens, and that will end up with what we call as hyperandrogenism. Also, androgen level will be elevated in primary gonadal disorders, primary adrenal disorders, because if there is an overproduction by a gonads, then also androgen level may be elevated, or by adrenal cortex, or maybe androgenic because it is given from outside from some other treatment, then we call that as androgenic. And particularly in a female, PCOS, polycystic ovarian syndrome, is one of the most common cause. In Cushing syndrome also there is a little elevated level of androgens. In congenital adrenal hyperplasia, there is quite a good amount of elevation of androgens, and sometimes androgen secreting tumors of adrenal cortex can also produce elevated level. So maybe exogenous, maybe endogenous, and endogenous are mainly two organs, one is ovary and second is adrenal gland. We already shown you this slide, maybe primary gonadal disorders or adrenal disorder or iatrogenic. This is excess of endogenous hormones, and particularly in female, PCOS, Cushing syndrome, congenital adrenal hyperplasia, and adrenal secreting tumors. Some of the androgen producing tumors in female: Sertoli leading cell tumors, lipid cell tumor, Hyler cell tumor, theca cell tumor, Brenner tumors, etc. So these are some of the tumor, and of those Sertoli leading cells tumors are the most common. They secrete androgens. In adrenal cortex, we already mentioned one condition, congenital adrenal hyperplasia, or you can have adenoma or adenocarcinoma, which may be also having adrenal androgen producing tumors. And in those particular female, you will have elevated level of testosterone and may be associated with, depending upon what is the source, ACTH level may be high or ACTH level may be low, along with other hormonal imbalance. And you can find out whether adrenal gland or ovary is involved by doing a pelvic ultrasound, CT or MRI. Androgens will usually give rise to hirsutism, and hirsutism is quite commonly found in PCOS, androgen producing ovarian or adrenal tumors, congenital adrenal hyperplasia, Cushing syndrome, certain drugs, even in obesity, and sometimes we cannot identify the cause also. We call that as idiopathic. We'll be dealing separately regarding hirsutism. We already mentioned PCOS, androgen secreting tumors, idiopathic hirsutism, idiopathic hyperandrogenism, etc. So these are some of the conditions which can also end up with hirsutism. This is one diagram showing you adrenal causes, ovarian causes. PCOS is one of the most common cause for hyperandrogenism in female. And in that particular, it is, we'll be discussing separately in PCOS, but there is an increased level of LH and androgen secretions. And FSH level is usually low. So I'm skipping over these particular slides. We'll be having again this particular. So there is a hyperandrogenism and there is a increased production of LH. You can have human gonadotrophic hormones also being elevated. So there is an abnormal LH secretions and there is a decreased production of FSH. In Cushing disease, because of oversecretion of ACTH from pituitary, and there is an adenoma or there is a presence of adenoma producing glucocorticoids, it leads to cortical hyperplasia and hypercortisolism. Along with hypercortisolism, you can have a hyperandrogenism also in case of a Cushing syndrome. In a congenital, we already told you because of deficiency of 21 hydroxylase enzyme, there is a increased production of testosterone leading to virilization. So this is the typical, there will be decreased production of aldosterone and cortisol, and there is an increased production of testosterone, or we call as androgens, because of defect in 21 hydroxy enzyme, which is necessary for production of aldosterone and cortisol. But for production of testosterone, we don't require 21 hydroxy, so you get continuous production of testosterone, and that will produce hyperandrogenism. So cortisol level is reduced, mineral corticoid level is reduced, excess of androgen is being produced, maximum quantity. So there is a basic lack of cortisol, aldosterone, but there is an increased androgens, and that will produce genital secondary sex character development will be abnormal, and also in female you will have a hirsutism and virulinization. You can have adrenocortical neoplasia, which may be secreting cortisol or maybe along with androgens. Main production of androgen is by adrenal gland and ovary, and that will be metabolized by skin, adipose tissue, liver and placenta. Typical manifestation of a hyperandrogenism will be acne, These are mainly in female: acne, acanthosis nigricans, irregular menstrual period, infertility, hirsutism, and hair loss. These are classical findings of hyperandrogenism in female. We already shown you this slide. There are a lot of other causes of hirsutism like PCOS, adrenal, androgen producing ovarian tumor or adrenal tumor, congenital adrenal hyperplasia, Cushing syndrome, some of the drugs, obesity, or maybe idiopathic also. We already told you primary adrenal disorders like Cushing syndrome, congenital adrenal hyperplasia, and adrenocortical neoplasia can have increased production of androgens, and that will produce this typical distribution. This is Cushing syndrome. You can see typical pigmentation, buffalo hump, etc. So you can have a Cushing syndrome signs, and along with that you can have a hyperandrogenism. And because of hyperandrogenism, hirsutism, male pattern of baldness, acne, deepening of voice, increased muscularity, and increased sex drive, uterus will be shrunken, there will be clitoromegaly, so clitoris will enlarge, breast will undergo atrophy, will become smaller, and female will have invariably amenorrhea. This is already we have mentioned, depends which part of the time you get this congenital adrenal hyperplasia. If it is perinatal or later in the childhood or in an adult, depending upon that you will have a different symptoms. Congenital adrenal hyperplasia, very classical, it is commonly seen in female. You can have a classical variety or a non-classical variety. In a classical form, you will have an ambiguous genitalis at birth. There is a complete fusion of labia scrotal fold and phallic urethra, clitoromegaly, partial fusion of the labioscrotal folds, etc. And that will give a typical formation we call as a classical form. In a non-classical form, genitalia, external genitalia are normal at birth. Precocceus pubic hair will be there, clitoromegaly, excess of facial and body hair we call hirsutism early in the childhood, and it will be accompanied by a tall stature because there is increased growth of the bones, long bones. So in a non-classical variety, you can have a pubarche and advanced growth, oligomenorrhea or amenorrhea, alopecia. Adolescent boys can have this early beard growth, acne, early growth spurts, infertility. All this can be seen if it is pre-puberty. This is typical, what we call as a non-classical. You will have a decrease size of external genitals, typical development, you will have a early loss of hairs, you will have a pigmentations, acanthosis we call. In a female, in a late onset variety, external genitals will be normal at birth, precocceus pubic hair, clitoromegaly, excess of facial and body hair will appear, tall stature, virulentizing symptoms will be present depending upon the severity of the androgen secretions, invariably oligomenorrhea or amenorrhea, and hirsutism, also infertility, and this will be the typical clitoromegaly you will see in early childhood. You can see typical. Classical variety we have already mentioned, ambiguous genitalis, female. In a female, most common, you will have a failure to gain weight, dehydration, shock, salt loss presentation with electrolyte imbalance. This is very commonly along with what we call as a mineralocorticoid deficiency, which will produce hyponatremia, hypochloremia, metabolic acidosis, and hyperkalemia. Also, there will be hypoglycemia because of glucocorticoid deficiency, hyperpigmentation, etc. because of high level of ACTH, hyperpigmentation. All these characteristics will be present, and then we call that as a classical congenital adrenal hyperplasia presentation. These are all what we have already mentioned. This is in female virulinization, ambiguous genitalia, clitoromegalis, precoccis puberty, and there will be early growth of pubic hair, amenorrhea, oligomenorrhea. This will end up with infertility, hirsutism, labial fusion, accelerated growth, and skeletal early height growth. You can have three varieties of presentation: salt losing with classical, where weight loss, weakness, hypotension, hypoglycemia, hyponatremia, anorexia, vomiting, dehydration, and metabolic acidosis. All this is because of mineralocorticoid deficiency. Or you can have a simple virulinization, non-salt losing congenital adrenal hyperplasia, where these symptoms are not common, and you have got more of virulinization symptoms, and this will be typical in female. And another type of presentation is we call non-classical variety or a late variety of congenital adrenal hyperplasia, we already mentioned. So you will have an additional finding like hyponatremia, hyperkalemia, hypoglycemia, hypertension, hyperpigmentation. This is because of associated glucocorticoid and mineralocorticoid deficiency. We have already mentioned this, so I'm skipping over this. In a polycystic ovarian syndrome, usually they will come to you with a menstrual disturbances, hirsutism, infertility, acanthosis nigricans, etc. And there will be increased level of LH, and person will also have a insulin resistance. So this will be very, very typical. And along with this, the ovary will have a multiple cyst, presence of more than 12 cysts, and ovary size is bigger, and that is diagnostic of polyovarian syndrome. This is typical acanthosis nigricans. These are those what we call as alopecia, acne, hirsutism, growth of hair on chest and abdomen, and also typical pubic hair, oligomenorrhea, amenorrhea. Along with, you will have a polycystic ovary, metabolic syndrome, chest will have a lot of hairs, etc. So, oligomenorrhea, excessive hair, infertility, hirsutism, acne, acanthosis nigricans, obesity, etc. are typical findings. And you will have a elevated level of androgens, which will be giving a symptom sign suggestive of hirsutism. And on ultrasound, will detect polycystic ovary. This is the difference between PCOS and increased hair growth, which is one of the disorder called hypertrichosis, which is autosomal dominant. I am not going into detail. If you are interested at your leisure time, you can go through. That will be, you can differentiate PCOS with hypertrichosis. One very important finding in PCOS, ovary size will be bigger, and on ultrasound you will be able to detect increased cyst, polycyst. So that will be very typical. And in PCOS, hirsutism will be very common, while in hypertrichosis, virilization will be very common. And what we call is a testosterone level may be normal or increased, while in hypertrichosis, it is markedly elevated, 8-fold times it is elevated. And here, FSH-LH level may be also affected, and that may be the important difference between the two. Androgen will have a small breast, muscle mass will increase because it is protein anabolism, so there is an increase in muscle mass. Because of excess of androgens in female, female will have an enhanced libido. Then pilosebaceous cyst will also have increased secretions. Hair growth will be abnormal, and that we call as a hirsutism. Typical hirsutism you will see, and depending upon the amount of hirsutism, we call Ferryman Galway criteria. You can label them mild, moderate, severe, etc. This is facial hair growth. You can see a small amount of hair growth. Clear? This is acanthosis nigricans. This is typical androgenic effects. There are a lot of photographs. This is typical distribution. You will have a loss of hair, acanthosis nigricans, typical hirsutism with acne also. We got virulinization, means a male character present in a female very frequently, that we call as a virulinization. So in a virulinization you get hirsutism, baldness, acne, change in the voice and muscular character and increased sex drive. These are typical virulinization symptoms. Along with that, in woman you will have a shrinkage of uterus, clitoromegaly, breast will undergo atrophy and amenorrhea. So these are typical virulinization symptoms. On ultrasound, CT, MRI, you will be able to detect the tumor size. And this is before treatment, this is after treatment. You can have androgen secreting tumors, etc. So clinically, if there are some symptoms and signs which is suggestive of hyperandrogenism in female or hyperandrogenism in male, you suspect, you do a screening part and then you go for investigations. And in investigation, first you have to demonstrate that the androgen levels are in excess. So testosterone level, dehydroepiandrosterone level will be elevated and those metabolic product will be also elevated. Then you have to rule out causes of androgen excess. So for that you will have to do a testosterone estimation at a different timings because there is a variable secretions, circadian secretions, and then you will have to find out that there is an excessive androgen secretions. And then you will have to also look for the metabolic abnormality because of excess of androgens. Along with that, good number of time glucocorticoid deficiency or deficiency of mineralocorticoid is there. So that will produce lot of other abnormality like glucose, lipids, electrolytes, etc. So try to have a look at those things. So in laboratory, you will do testosterone and dehydroepiandrosterone level, DHEA level, serum prolactin level, because in hyperprolactinemia also you can have an abnormal production of androgens. TSH level is important to find out the other causes of increased production of testosterone like pituitary disorders. Serum 17 hydroxyprogesterone level is done in a suspected case of congenital adrenal hyperplasia. LSH, FSH level mainly in case of PCOS because LH level will be elevated, FSH level will be low. Lipid profile and GTT will be important to find out the secondary effects of androgens as well as other hormones on lipids and what we call as a glucose. Transvaginal examination is very useful. We call transvaginal sonography, which will give you a good idea regarding the ovary, and polycystic ovary can be better picked up by that. So you can go for TVS. This is transvaginal sonography. So you try to detect polycystic ovary, multiple cysts, more than 12 definitely goes in favor. So these are multiple cysts. So more the number of cysts, more in favor of polycystic ovary. Along with those high level of testosterone and DHEA, dihydroepiandrosterone, there will be hyponatremia, hypochloremia, hyperkalemia, metabolic acidosis, hypoglycemia will be very common. Even you might have an elevated level of urea. We already told you, you should do androgens level, particularly DHEA and testosterone level, and also 17 hydroxyprogesterone level. That level will be elevated. In a particularly in a congenital adrenal hyperplasia, you will have a low level of cortisol, with high level of ACTH. Even aldosterone level will be low with high level of renin. This is very peculiar in case of a congenital adrenal hyperplasia. So investigations very important is suspicion will be there by examination of external genitals. You can go for urinary examination for metabolic products of testosterone, cortisol, aldosterone, etc. Then you can go for blood test, hormonal assays. As far as localizing the tumors, CT scan, MRI, ultrasounds, urogenitography to find out the abnormality which can be congenital abnormality, and you can go for genetic testing and karyotyping. So these are all the additional investigation to find out genetic defects. These are some of the three common abnormality which you can see in hyperandrogenism, that is PCOS, congenital adrenal hyperplasia, and idiopathic hirsutism. In idiopathic, you can see that LH level, dehydroepiandrosterone level, and testosterone level, all three are normal, or 5, even we can call as a 17 hydroxy epiandrosterone or a progesterone. So that is also normal. You will have mainly abnormal production from skin, and that will give rise to hypertrichosis. And menstrual period will be absolutely regular, while in this too it will be irregular. Testosterone level will be elevated in PCOS as well as congenital. LH level will be elevated in PCOS but usually normal in case of congenital adrenal hyperplasia, and this is 17 hydroxy progesterone level will be markedly elevated while it will be normal in PCOS. This is an important difference to find out. While testosterone level are elevated or androgens level are coming from ovary, while here it is from adrenal hyperplasia. So this will be very important. So you can differentiate between these three conditions. At your leisure time you can go through. This is a flow chart in hirsutism. If FSH level, if you do, that will give you an idea regarding an ovary, where LH level will be high in PCOS and FSH level will be low. By doing an testosterone, dehydroepiandrosterone, and what we call is a sex hormone binding globulin, if it is normal, it almost rules out what we call as gonadal disorders. Gonadal disorders, if it is absolutely normal. By doing an ultrasound, you will be able to rule out ovarian causes and adrenal causes. So ovary causes, adrenal causes will be ruled out very nicely. If ultrasound is normal, it is almost giving you idea that ovary and adrenal glands are normal. So good ultrasound, testosterone level, FSH LH level, and then we call dehydroepiandrosterone and 17 hydroxy progesterone level, which will be very high, particularly in a congenital adrenal hyperplasia. So try to estimate that. That will give you an idea regarding. So this is what we have mentioned here. Same thing is shown here. So that will be. Management will depend upon the basic etiology. But in general, diet, medication and surgery becomes very important in certain tumors, particularly adrenal and ovarian tumors. Treatment is usually lifelong steroid replacement. Hydrocortisone, or we call glucocorticoid, has to be replaced, and fludrocortisone in a person with congenital adrenal hyperplasia, because these are deficient. So hormone replacement therapy will be very useful in a congenital adrenal hyperplasia. Those two are elevated. You might require a plastic surgery for ambiguous genitalis. Genetic counseling is absolutely necessary because it is an autosomal dominant disorders, and you will require a psychological support. So already we have mentioned, this is what we have shown you in this previous slide. If a person develops adrenal crisis because of severe cortisol deficiency and mineralocorticoid deficiency, you will require to treat adrenal crisis, which we have already discussed in detail in adrenal gland Addison's disease. You will require to give injectable form of hydrocortisone with mineralocorticoids, IV fluids, electrolyte balance corrections, etc. So usually you will require glucocorticoid therapy and mineralocorticoid therapy. And even for androgen, glucocorticoid therapy will be very beneficial because that will help to reduce the androgen productions. So goal of glucocorticoid therapy is to replace cortisol as well as prevent virulinization, to optimize the growth of the body and protect potential adulthood fertility. So this is the main use of a glucocorticoid. But still, you don't get a good results. Fluorocortisone will be mainly utilized if there is a mineralocorticoid deficiency. For a hirsutism, general measures: stop the offending drugs if it is androgenic. If there is a tumors of adrenal gland or of ovary, surgical removal or surgical treatment. And if there is any medical disorders, then treat the medical disorders. By a cosmetic measures, hair can be removed by shaving, waxing, epilation, electrolysis, laser therapy, etc. Weight reduction can be done as a first line of treatment in PCOS, particularly if it is markedly obese. Mainly monotherapy, that is oral contraceptive pills, is the first line of treatment for hirsutism. Oral contraceptive are the first line of drug to be used in hirsutism. So that is very, very helpful. You can use a combination of progesterone with ciproacetate or drosophilone, add benefits of cycle regulating contraceptions, etc. Metformin is also being utilized in PCOS, which will lower the insulin resistance, decrease the androgen levels, and improve ovulation. It will also increase insulin sensitivity, thus reducing what we call as a hyperglycemia, as well as it will also help in reduction in obesity. Start with a low dose and gradually increase every 3 to 4 weeks. By and large, good time. They use multiple drugs. Hello. Sorry, હમણાં હું એક લેક્ચરમાં છું, પછી ફોન કરો. હા, ઓકે ઓકે ઓકે. So you will require an external hydrocortisone, you will require a mineralocorticoid, and you might also require what we call as the estrogens, depending upon the clinical symptoms and signs. So you will require to treat at different level, and sometimes you may require even other treatment. Here we already mentioned in a congenital adrenal hyperplasia, mineralocorticoid, glucocorticoid deficiency is there, so you will require to replace them. Along with that, you will require to correct effect of lack of mineralocorticoid, etc. And also you will require to treat hyperandrogenism. So glucocorticoid treatment becomes very useful. While treating, you have to maintain a very nice balance between over treatment and under treatment. If you don't treat properly, there is no improvement. If you treat with more dose for a longer period, excessive dose, you will end up with a Cushing's, and you will end up with lot of complications. And in complications, because of hyperandrogenism itself, acne, acanthosis, abnormal external genitals, irregular menstrual period, amenorrhea with infertility, hair loss, virulinization, hirsutism, acanthosis nigricans, all those things you will be looking at. And we already told you, because of lack of mineralocorticoid in a person with congenital adrenal hyperplasia, you will develop hyponatremia, hyperkalemia, hypotension, metabolic acidosis, and because of glucocorticoid excess lack, you can have hypoglycemia, hyperpigmentation because of excess of ACTH, etc. So this will be all symptoms and signs which you can develop. So I end my lecture here. I hope this will be helpful to you. Once in a while, you will see this particular group of people in your everyday practice.